Good afternoon, judges and my colleagues. I am excited to present to you a scale which you will be able to use for an objective assessment of magnitude of accommodation in kids, even very, very young kids. I have no financial interest so far. Accommodation in children is not frequently measured despite of a significant number of disorders which affect accommodation in children, such as Down syndrome, cerebral visual impairment, foveal hypoplasias, ectopia lentis, patients with unilateral or bilateral amblyopia, strabismic disorders with accommodative abnormalities, children with asthenopia, and nowadays with lots of use of low-dose atropine. At present, the dynamic aberrometry and open-field autorefractometry is not accessible commonly, and it is marred with underestimation of accommodation in children. Also, very young children cannot be put on these instruments. Hence, most pediatric eye surgeons would like to rely on dynamic retinoscopy. In our survey of pediatric eye surgeons of Mumbai in 2019, we found only 1 out of 18 pediatric eye surgeon was confident enough to be able to estimate accommodation in children when it was required. So we described this technique long back, wherein you use a direct ophthalmoscope and ask the child to look at the distance and read, and then look at the object at near, which is approaching the eye. And as the child would do that, you will find change in the reflex called Bruckner's reflex from superior crescent to an increasing inferior crescent. As documented in this video, child looking at the distance will have a superior crescent, and as soon as the child would start looking at near, you will find a crescent superiorly disappearing and an increasing, well-sustained crescent coming inferiorly. We coined a new term called dynamic distance direct ophthalmoscopy and published twice in Indian Journal of Ophthalmology in 2012 and 2019, and validated this technique with a very good intra-test and inter-test observer variability, as well as a very good correlation of almost 100% with the current gold standard, which was dynamic retinoscopy. If you neutralize the inferior crescent using a lens rec, as you see over here, you will be able to find the exact magnitude of accommodation. However, despite of describing this technique, even our colleagues in Mumbai were not able to start using it. So we decided, let's get rid of using the interjection of the lenses and create an accommodation scale and then validate it. The way scale was derived was like ask a child to look at a distance who was emmetropic and then introduce the plus lenses to simulate the accommodative reflex. In a step of 0.5 diopter from 0 to 5, we were able to derive this kind of an accommodation scale with 11 pictures in it, which is similar to the scales available and were used in the past, like the pupillometer scale, the corneal ulcer diameter scale, the cup disc ratios that we decide are based on similar kind of concept. To detect 0.25 diopter difference in accommodation at a 90% power and at 5% statistical significance, our pediatric optometrist had to involve 15 eyes of 15 patients. And we included children between 5 and 16 years of age who were normal in health and visiting pediatric eye clinic for their routine refractive checkups. Both the techniques were performed at 4 different distances. As you see over here, the accommodation scale we felt was having less intra-test variability as seen by less standard deviation, as well as it did not induce the accommodation lead as was in the gold standard. So it was in fact better than the gold standard. Then we validated it among pediatric eye surgeons of Mumbai. We showed them 10 different scenarios and asked them to match what would be the accommodation. And this is exactly how clinically you will be using the scale. Like the lower panel, you match it up with the upper, and where the child is looking will decide whether there is a lead or lag of accommodation or normal accommodation. The only limitation of this technique, I think, is still the lens interjection was used, and hence in the previous picture you can see an extra reflex. Also, I still feel it's not going to be picked up by pediatric eye surgeons across. People would like more of technology and, of course, having something which is better documented. For now, I think accommodation scale is here to stay. It is a very easy and rapid method to assess accommodation in children objectively. Thank you very much.
You have shown high statistical significance. So what was your significance test that was done? What test was done statistically to show the significance?
So, madam, we used two tests. One is the Pearson's R,
Yeah.
it's a correlation coefficient. With the intra-test variability, for that we used the t-test, and the paired t-test was
You've
used.
used a paired
because the
because
same child
same.
was assessed on two in sequence.
Thank you.
Thank you.
Thank you, Dr.